Good evening. I am Doris Mosley, and I am honored to serve as the president of the Richmond, VA chapter of the Links Incorporated as we celebrate 70 years of distinguished service to the community. Our chapter is a member of an international not-for-profit corporation established in 1946. The membership consists of more than 17,000 professional women of African descent in 299 chapters located in 41 states, the District of Columbia, the Commonwealth of the Bahamas, and the United Kingdom. It is one of the nation's oldest and largest volunteer service organizations of extraordinary women who are committed to enriching, sustaining, and ensuring the culture and economic survival of African Americans and other persons of African ancestry. I am pleased to welcome you to this Men's Health webinar, Understanding Prostate Cancer, and thank you for taking time out of your schedule to learn more about prostate cancer screening, early detection, prevention and treatment, and care. This webinar is sponsored by the Richmond VA chapter of the Links Incorporated and Virginia Urology. Again, welcome, and thank you for attending this webinar.
Good evening, guests, members of the Richmond, Virginia chapter, and members of the Links Incorporated. My name is Monica Brinkley Davis, and I serve as the program coordinator of the Richmond, Virginia chapter of the Links Incorporated. The purpose of tonight's webinar is to provide information specific to prostate health. We are proud to partner with Virginia Urology to present this event. We have invited our chapter member, Dr. Tamara Charity Brown, to moderate tonight's discussion. Dr. Charity Brown is a double Wahoo, graduating from the University of Virginia in both 1997 and 2001. She is a partner at Associates in Pediatrics in Glen Allen, Virginia, and has over 21 years of experience in the medical field. In addition to her role as a pediatrician, she is the wife of Carlos Sr. and mother to Carlos Jr., Charity, CJ, and Carrie. Please help me welcome Dr. Tamara Charity Brown.
Good evening, everyone. Thank you for joining us this evening. So I have the pleasure of introducing our guest. So I will give you some information about him. What we'll do is our guest speaker, Dr. Orton, will start with a slide presentation, just giving us some background on prostate health and prostate cancer. And then we will take questions as well. If you have questions, please put them in the Q&A section. So not in the chat section, but in the Q&A section, and we'll make sure to address those. So Dr. Orton grew up in Portsmouth, Virginia. For his undergraduate education, he attended Morehouse College in Atlanta, Georgia, where he graduated Phi Beta Kappa with a BS in biology. He obtained his medical degree from the Medical College of Virginia. He then completed his general surgery internship and urology residency at Virginia Commonwealth University. Dr. Orton achieved additional laparoscopic and urological robotic surgery training at a one-year fellowship at City of Hope National Medical Center. His clinical interests include urologic robotic surgery, treating oncological and benign disease. He also has clinical interests in benign prostate disease and stone disease. In his spare time, which I'm sure he doesn't have too much of with his busy schedule, he loves spending time with his family, traveling, and listening to music. So at this time, I will allow our guest speaker to start his presentation. Thank you.
Thank you, Dr. Brown. I really appreciate that introduction. Thank you, members of the Richmond, Virginia chapter of the Links Incorporated, for the invitation. I'm honored to be here and to discuss prostate cancer with all of you and all of the attendings this evening. I have to give a special thank you to my cousin, Ioana Dabney, for coming to me and asking if I'd be interested in having this discussion with everyone. And I told her absolutely I'd be 100% interested having this discussion. For it's something that I'm passionate about, and it's something that I see many patients about each day regarding prostate cancer and their prostate health. I do have to pause for a second because I was looking at the attendees in the chat, and I saw Evelyn Orton in the chat, and that's my mother. So it's not often that I get an opportunity to give a presentation in front of my mom. So this is a special presentation that I'm giving this evening, and I think maybe some other family members may be joining as well. So thank you to everyone in attendance, and I will start my slideshow. So I always like to start by just informing everyone that I don't have any disclosures to announce. I love to start any presentation with a slide of my family and my kids. As Dr. Charity Brown mentioned, I really am a family person, and I love my family and I love my children, and all those that aren't pictured on this slide here. I think one of my kids might be off to the side. Hopefully everyone else can see it. He's kind of behind everyone here in the corner. But it's I always tell my wife Megan, it's, you make time for those things that are important to you, and I wanted to just take a minute to recognize everyone here in this photo. All of my little ones. I told my middle son, who's right here, that he's trying to steal the show by sending me a picture of, marry me. He recently got engaged, and we're all very excited for him. But that's the first picture that he sent me before he sent the one that doesn't really steal the show. But I wanted to share all of the family that keeps me going, immediate family that keeps me going with all of you. As Dr. Brown mentioned, I did a lot of my undergraduate, not undergraduate, but medical school and residency training at Virginia Commonwealth University. And then I was an attending there for many years, from 2010 to 2016. And I trained residents as well as trained other attendings in robotic surgery, as well as treating men with prostate cancer. Prior to coming back to VCU Health, I attended a one-year fellowship at City of Hope, which is probably one of the busiest robotic surgery hospitals in the country, for which primarily most of our cases that we would perform are robotic prostatectomy, helping men that have been diagnosed with prostate cancer. It was great training, and I'm very, very happy that I did that training. After my years at Virginia Commonwealth University as an attending, I spent 5 years on the West Coast and just north of Seattle, for about an hour and a half north of Seattle, in a small town called Bellingham. And I was a physician at Bellingham Urology. It was a small private practice group, and this was the first time that I was out of academic medicine in private practice. Just last year, I returned to Virginia, closer to family, and we're so happy to be back in the area to join Virginia Urology. And I've actually just completed my first year, September 30th, at Virginia Urology, and it is going very, very well. So I like to start with this slide because before we talk about prostate cancer and the early detection, the screening of prostate cancer, the treatment and follow-up of prostate cancer, we have to understand what a prostate is. We have to understand where a prostate lies. And so I put this anatomy slide in to illustrate that. The prostate gland is the male sex gland that is located between the bladder, where the urine is stored, and the urethra, for which the urine passes through prior to a man urinating. This prostate gland, its main function, or one of its main functions, is when men are in their adolescent years, is to convert testosterone to a more active form of testosterone. But when men are out of that period of adolescence, the prostate doesn't have as much function as it does during those years. It does contribute to some of the constituents of semen, but more so than anything else, as men age, it causes more problems than anything else. And so it's located here. Normally, the size of a prostate is about the size of a walnut, or we say about 20 grams. So the question that many men ask is, should I be screened for prostate cancer? This question takes into account, one, that men are thinking about being screened for prostate cancer, two, that their primary care physician has encouraged them to be screened for prostate cancer. And so it's a question that really needs to be prompted by those in the medical community to men. And I'll get into which men are in the category of needing to be screened. But it's really a question that might not be asked of any gentleman in his 40s, 50s, or 60s if they are unaware of the prostate, of its functions, and of the implications if you are not screened. So that's the first question. Should I be screened for prostate cancer? And this is why men should be screened for prostate cancer. Prostate cancer is going to be the number one cancer that is diagnosed in men. You can see from this chart here, it's a little not too dated, 2018, and the source is the CDC, that it's going to be the number one cancer diagnosed in men, and after that it's going to be lung and bronchus cancer, so lung cancer. And another reason that men should be screened for prostate cancer is because it's going to be the number two cause of cancer-related death in men behind lung cancer. And so it's very important that the question of should I be screened for prostate cancer is presented to a patient, and it is something that is brought up by their primary care physician. Screening consists of two elements. Screening consists of some blood work as well as the digital rectal exam. And I can tell you that I saw almost 30 patients today, of which 20 of them were coming to see me for prostate cancer or for prostate cancer screening. And it is a little bit of some hesitancy in many men in undergoing part of the prostate cancer screening, which is the digital rectal exam. I really believe that causes a lot of men hesitancy from going to the physician, and it is something that we all need to encourage men and support them in understanding the importance of it. So the digital rectal exam, which is a finger in the rectum to feel the prostate, is absolutely necessary in screening men for prostate cancer. What also is important to screen men for prostate cancer is the prostate-specific antigen, or commonly referred to as the PSA. What it is, it's a glycoprotein that is made by cells within the prostate gland, and it's a blood test that is measured. Doesn't have to be a fasting blood test. It can be obtained any time of the day. A normal PSA ranges from 0 to 4. That range is a little bit higher, from 0 to 5.5 or 0 to 6.5 in men as they age. And the reason is because the PSA is a good test. It's not a great test. And I say that because it's not specific for prostate cancer alone. The PSA can represent inflammation of the prostate. It can represent infection of the prostate. It can represent enlargement of the prostate, which many men as they age, they have. but it can also represent prostate cancer, and that's what we are concerned about. So anytime I see a patient that has a PSA that is above 4, if it's their first PSA, the first thing I do is repeat it, just to ensure that there's no lab error, or that there was no infection or inflammation that is contributing to their PSA being outside of the normal range. Once repeated, if their PSA continues to be beyond the normal range, then we need to initiate a workup of why that may be occurring. I love this slide, and this is a slide that I put together. I did a presentation not too long ago, and unfortunately, this slide did not make the slideshow, and I was pretty upset about it, but it made it today, so fantastic. So originally, this is the history of PSA, and this is a really important slide because there was a moment in treating men with prostate cancer that PSA screening was recommended, and then it became a non-recommended test. Then it became recommended again, and it was at that point in time that we lost a lot of our primary care physicians in recommending this to many men. And so in 1986, the FDA approved the PSA as a blood-based test to monitor men that already had disease. Now, I will say that prostate cancer prior to the PSA blood test was diagnosed very late. Many of these men had symptoms of prostate cancer, and that's not the case nowadays. When men have symptoms of prostate cancer, it's advanced prostate cancer at that stage. And so in 1986, they were using it specifically for men that had to monitor for progression of disease. And so that was a little late in the treatment course of prostate cancer. In 1994, in conjunction with the digital rectal exam that I just explained, we were able to utilize the PSA for men that were not having any symptoms for prostate cancer. And it was after this time that we really started to see in studies retrospectively and prospectively, men that were having prostate cancer that was localized, prostate cancer that was treated prior to the onset of any symptoms. And so we saw the mortality of prostate cancer decline. We saw the morbidity of prostate cancer decline. This was after 1994. In 2012, the United States Preventative Service Task Force recommended that prostate cancer was a grade D recommendation. And what that means is that they no longer recommend prostate cancer screening. And so men weren't now able to be diagnosed early with prostate cancer through PSA screening. We saw a significant decline in those men that were screened, and we saw a significant increase in those men that were diagnosed with more advanced disease and more symptomatic disease. Fortunately, studies were done, and in 2017, they changed their grade D recommendation to a grade C recommendation, which means that men should be offered prostate cancer screening, understanding the risk and benefits of screening. And one reason, well, there are two studies that I'll talk about in just a second, but there's also another reason that this was adapted in 2017 is because we as urologists realized that not all men with prostate cancer needed to be treated. We could safely watch some men with prostate cancer without any progression of disease, and we did not have to subject them to the side effects that many treatment options for prostate cancer can cause. And so it was a good decision, in my opinion, that we went from a grade D recommendation to a grade C recommendation. And the two studies that, and this is a little technical, so I won't go into it in too much depth, that occurred with the European randomized study of screening for men with prostate cancer. It was commonly referred to as the European study. And what they found is that if you screen men, it prevents 1.28 men from dying of prostate cancer, and it lowers the risk of men with more advanced or metastatic prostate cancer. Metastatic prostate cancer is prostate cancer that is spread beyond the level of the prostate. The prostate, lung, colorectal, and ovarian, the PLCO cancer screening trial was commonly referred to as the American study. Also saw that there was a reduction in prostate cancer specific death or mortality. This wasn't clinically significant, but it did trend in that direction. This made headlines. I mean, and when it made headlines, and it called, our patients had a lot of questions of should they be screened, should they not be screened, what are the risks of being screened? And there was a lot of, and there still is, I believe, a lot of hesitancy in the medical community to screen men for prostate cancer, because it takes the urologist that is understanding of we can safely watch prostate cancer to screen men, and then if someone's diagnosed with prostate cancer, to treat them appropriately. What we don't want is to screen men, lead to an overdiagnosis and an overtreatment of prostate cancer, because we're subjecting men to potential harm and disease that may not impact them, meaning that it might not extend their life expectancy by treating the disease. This is the recommendation that the United States Preventative Service Task Force recommended in 2017. It changed, as I mentioned, from a grade D to a grade C recommendation. And it recommends that men ages 55 to 69 are informed about the potential harms and benefits of prostate cancer screening, or PSA prostate cancer screening. This is a little wordy, but essentially that's what they recommended. This is one agency that recommends prostate cancer screening. Also, the American Cancer Society has recommendations for prostate cancer screening and early detection. They recommend men ages 50 with average risk and a greater than 10-year life expectancy are offered prostate cancer screening. For men that are high risk, those are men that are 45 that may have Black men in their family, first degree relative that may have been diagnosed with prostate cancer at an early age. And then men ages 40 that are at even higher risk with first degree relatives with prostate cancer. The American Urologic Association, the AUA, has a very similar recommendation is very similar to the United States Service Preventative Task Force, men ages 55 to 69, but that's just a general recommendation. We can recommend prostate cancer screening based on one's family history, their first degree relatives, and also even if there is a strong family history of female breast cancer, ovarian, or pancreatic cancer, because studies have shown us that these men can also be at increased risk for developing prostate cancer. The panel doesn't recommend routinely PSA and prostate cancer screening for men over the age of 70. The AUA, the American Cancer Society, as well as the United States Services Preventative Task Force. However, if men are 70 or 75 and they're healthy, if they have a greater than 10-year life expectancy, then there's nothing wrong with offering those men prostate cancer screening. And I've offered that to several men. So there is a little bit, these aren't strict, hard rules that we have to follow. They're just guidelines for screening men for prostate cancer. These are the pros of PSA screening and prostate cancer screening. early detection is better. So certainly PSA screening helps us to detect prostate cancer. The majority of prostate cancer in its early stages will have no symptoms. So the only way that you're going to be able to diagnose this is through prostate cancer screening. When detected early, it's more likely to be curative. As we see this in medicine, not just with prostate cancer, but with other cancers as well. The PSA blood test is a simple test. It's a test that we actually, for many men come into our office, they're able to get the test the same day, and then I'm able to review that result with them prior to the conclusion of their clinic visit. The testing can provide a certain amount of reassurance. It can let men know if they're at risk or if they're not. And so many men with a PSA between the levels of 0 and 4 are reassured that their risk of prostate cancer is very, very low. And then, as I discussed earlier, the number of deaths from prostate cancer has decreased since the use of the PSA blood test. Now, there are some cons to PSA screening. Some prostate cancers are slow growing and never leave the prostate gland. And as the urologist and as a patient and being your own advocate, it's important to have this discussion with patients. Many prostate cancers that are low risk or very low risk will remain that way, and many men can live with this prostate cancer and may ultimately end up dying from other causes. And so it's important that we as clinicians don't act immediately to treat all prostate cancer, because we would be doing more harm than good. The second bullet point here says not all prostate cancers need treatments, and yes, they have risk and side effects. With any prostate cancer treatment, there's risk of men having difficulties with urinary control, and that's because of where the prostate lives in relationship to the bladder and the urethra, that's the channel through which you urinate. Men can have difficulties obtaining erections as well, and that's because the nerves that are responsible for erections lie in very close proximity to the prostate gland. And so any treatment can involve those nerves as well, and those nerves can sometimes be compromised. As I discussed earlier, the PSA can be elevated when no cancer is present. And the reason that is because there can be inflammation, irritation, or infection, or just an enlargement of the prostate that also can cause the PSA to rise. And then a diagnosis of prostate cancer, if a patient is diagnosed, can create a lot of anxiety and confusion. I saw a patient earlier this week who had very low risk prostate cancer, and I could see they were visibly having a difficult time with the diagnosis. Now I know, and I can say to the patient, that it's very unlikely that this prostate cancer will affect you in your lifetime, but it does provoke anxiety, knowing that you have a diagnosis of cancer, knowing that it can safely be watched. But some men don't have the ability their anxiety won't allow them to do that comfortably. And so they may make the decision to undergo treatment, which is fine because we have a lot of treatment options to treat men, even with low risk prostate cancer. But they may be subjected to the morbidity and side effects that can sometimes come with prostate cancer treatment. This is how we diagnose prostate cancer. Men undergo what's called a transrectal ultrasonic guided prostate biopsy. And essentially what that means is that we use an ultrasound that we can place into the rectum. With that ultrasound, we can visualize the prostate. After giving a patient some antibiotics to limit the risk of infection and giving them some numbing medication to limit any discomfort, we can take biopsies of the prostate. We target a specific area of the prostate. It's called the peripheral zone, excuse me. There are other zones of the prostate, but this peripheral zone is where the majority of prostate cancer develops. And in biopsy in this area, systematically, generally we take about 12 biopsies. We can send that tissue to the pathologist, and the pathologist lets us know if there's any prostate cancer present. Now, with the use of the MRI that you can see down here in this corner, we can highlight and outline areas that are concerning for prostate cancer. The MRI is a good adjunct to our diagnosis, to help us diagnose men with prostate cancer. It's very good at identifying areas of intermediate risk or high risk disease for prostate cancer. It might not be able to identify low risk prostate cancer, but many times low risk prostate cancer is not the type of prostate cancer that we are concerned about. So if a patient is to get an MRI, and if there is an area that is identified on the MRI, then we can target the MRI with an ultrasound during our biopsy. This has helped improve our accuracy of detecting prostate cancer with the utilization of prostate ultrasound. I'm sorry, prostate MRI, excuse me. So what treatment is best for me? And this is at the point where a patient has now been diagnosed with prostate cancer. He has he has received this diagnosis. Generally, I tell patients on the time of their diagnosis not to make a decision, but to just listen to the information that I've shared with them. I provide them with some resources to read about newly diagnosed prostate cancer, and then I bring them back to clinic. And at that time, we have a discussion, a more in-depth discussion, a discussion where I think the content of what is being stated will be better received by the patient at that time. And so the treatment options are discussed at that time. The treatment options range from watchful waiting, active surveillance, radical prostatectomy, which is surgical removal of the prostate, radiotherapy, which is radiation, androgen deprivation therapy, which is the use of hormones to help treat the prostate cancer, cryosurgery, and what's called HIFU, or high intensity frequency ultrasound. Watchful waiting is just as it describes, as the words describe. It is a treatment that many times is offered to men that are of older age, that may have significant medical comorbidities, for which the treatment of their prostate cancer, many times low risk prostate cancer, is unlikely to improve or extend their life expectancy. So those men undergo watchful waiting. The protocol is to just treat men should they develop any symptoms. We don't check any lab work. We don't do any rectal exams. That is different from active surveillance, where it's a protocol that we utilize to actively follow men that primarily have very low risk, or what we call favorable intermediate risk prostate cancer. It consists of checking the PSA anywhere from every 3 to 6 months, to performing a rectal exam anywhere from 1 to 2 years. And then I also incorporate some genomic testing to ensure that the diagnosis of low-risk prostate cancer and that pathology in that tissue that was obtained during the biopsy truly represents low-risk prostate cancer. Or the genomic testing can tell me if it is representing something more like an intermediate risk or high-risk prostate cancer. And if it is, then many times I offer active treatment, which is those treatments that you see listed below. Active surveillance also, I utilize the prostate MRI to ensure that there are no areas concerning in other areas of the prostate that we don't typically biopsy. As I mentioned earlier, we biopsy the peripheral zone, but the prostate has other zones, the central zone, the anterior zone, the transitional zone, and those areas sometimes harbor some prostate cancer. So if a patient's on active surveillance and we get an MRI and it detects an area in a different zone of the prostate, many times we would recommend that patient not to continue with active surveillance, but to consider some active treatment. We might even go on to biopsy that area that has been identified to see if there's more clinically concerning disease that's present. So I'm going to talk a little bit more about each treatment of prostate cancer. HIFU, or high intensity frequency ultrasound, is a newer treatment modality for men with prostate cancer. It uses ultrasonic waves to target the prostate, and in doing so, it can treat men with prostate cancer. Primarily, this is used for men that have low-risk prostate cancer. It's also more utilized in Europe than it is in the United States. It's not a treatment recommendation that is commonly offered to men. Cryosurgery is a freezing of the prostate, and it's a cycle of freezing and thawing of the prostate gland that kills the prostate cancer. It's a therapy that's been around a while. It also is not offered to men many times that are of younger age or that have more intermediate risk or high risk disease, because the data doesn't support it treating men very well that have that type of prostate cancer. Several of my partners offer this treatment, and many times it's offered to men that are in their late 70s or 80s that have prostate cancer that they need to undergo treatment, but they may not be able to undergo treatment with surgery or radiation. Radiotherapy, it comes in a couple of forms. This is a linear accelerator for which can offer external beam radiation or immune modulated radiation treatment for men with prostate cancer. It's a series of treatment that men come to the radiation center once a day, each day for a period of 6 to 8 weeks. The radiation oncologist determines how much radiation to administer, the dose to administer, and then the radiation oncologist also determines if it is necessary for men to undergo some additional treatment with androgen deprivation therapy, hormone treatment. And this is really just based on the risk of the prostate cancer. What is the patient's PSA? Is it less than 10? Is it between 10 and 20? Is it greater than 20? What are their biopsy characteristics? Is it very low risk or low risk prostate cancer? Is it favorable intermediate risk prostate cancer? Is it unfavorable intermediate risk prostate cancer? Or is it high risk prostate cancer? All of those factors go into the decision making of how much radiation one will receive when they've decided to proceed with treatment of their prostate cancer through radiation. I offer treatment for men that have low risk, intermediate risk, or high risk prostate cancer. I offer treatment with the surgical removal of their prostate. This is the Da Vinci surgical system, for which we can utilize a robot to remove men's prostate that have been diagnosed with prostate cancer. Prior to this robotic system, men could undergo, and some men still today, undergo removal of their prostate through open, more traditional surgery. There are some characteristics of men's health that may be the better operation for them. But the majority of men throughout this country now undergo treatment of their prostate cancer through the utilization of the robotic surgery system. There are three elements to the robotic surgery system. There is the vision tower, there's a surgeon console, and then there's the patient cart. And with this, with robotic surgery, what we're able to offer our patients are the same principles that are maintained with open surgery, but we are able to offer them less pain, less blood loss, quicker recovery, and smaller incisions. Many of these men will go home the same day or the next day after their surgery. They will have a catheter in their bladder for about 1 week, at which time they will come back to our office and we will remove that catheter, and then they will start their recovery, or they will continue their recovery from the surgical removal of their prostate. This is a diagram of the relationship between the surgeon console, the vision cart, patient cart, and how it relates to the patient on the table. The patient cart comes directly up to the patient, and very much like laparoscopic surgery, we use small trocars to small devices for which we can enter into a patient's abdomen and then do our surgery. We have an assistant that is right beside the patient, and then an anesthesiologist at the head of the table, and a nurse that we utilize as well. The surgeon is not directly beside the patient. The surgeon is at the surgeon console. This console can be inside of the operating room, but the console can also be outside of the operating room in a common area. This is what it looks like inside of the operating room. This was taken at the Veterans Hospital when I was employed there. And you see the surgeon's console that is in the operating room. You see the table for which the patient will lay on, the patient cart, and the vision cart prior to a patient coming into the operating room. And so I wanted to just show you, and hopefully this works, a video of Vit Patel. He's a very, very well-known urologist who operates out of Celebration, Florida. He's one of the leaders in robotic surgery and treating men for prostate cancer, someone that I learned a lot from. And I just wanted to give you an idea of how it appeared when we're doing this robotic surgery. All right, so I'm going to pause it for a sec to be able to outline what you're looking at here. These are two of the robotic surgery instruments. Actually, 1, 2, and then there's a third one down here. This third one is actually pulling on the prostate. The prostate, I'll outline it for you, is right here. It's kind of all red, but you can visualize it right there. This here is just some tissue that is on the anterior surface of the prostate. This structure here is a catheter that is through the patient's penis on the outside, through the urethra, which is the channel that the patient urinates through, into the prostate, and then it's coming out here. It's no longer going into the bladder because the bladder has been detached from the prostate at this level. And so I'll just play the video here so you can kind of see the movements of the robotic surgery system. And so what he's just pointing out there is a vein that is on top of the prostate. You have to tie that vein off or come through it with a stapler, or some urologists just kind of go through it. It's all the surgeon's preference, but you can tie it off, and this just helps prevent any bleeding when you go to remove the prostate. And this is what he's doing here. You can see the camera moving in and out. He's also controlling the camera as he's doing the surgery. And this is in real time. It's not sped up or slowed down. He's a very efficient surgeon. And as he's just tying this off, at some point you will see him come through this, but I needed to get back to the full video, sorry. Now I'll just kind of speed ahead. And he's just pointing out that structure that's on top of him. Now, after it's tied off, he'll start to come through this structure. And by tying it off, it has very little bleeding here. Now, once he comes through the vein that's sitting on the top, he'll get down to where that catheter is that we saw on the other side of the prostate. And he has very good control of the vein that's on top of the prostate because it's not bleeding here significantly. And I'll just advance forward a little bit more as he's just, there we go. Here is the urethra, and here's the prostate, clearly outlined. He'll come through this urethra and then remove the prostate. The prostate will be free, and that will conclude the surgical removal of the prostate. It's at that point that he will have to sew this area here, which is the urethra, back to the bladder. You can't see it on this frame, but it's beyond the level of the prostate there. The catheter has been removed here. He's just checking behind the prostate. It's in very close proximity to the rectum, so it's important to ensure that you have a good separation between the prostate and the rectum, and that's what he's doing. You can see the robotic surgery system allows for very precise dissection. And after a few more cuts here, this prostate would be completely free. I have it on mute. He's doing some talking as he's dissecting as well. So he's just showing that the surface of the prostate is nice and clean. As I mentioned, those nerves that are responsible for erections run right here. They're in very close proximity, and he's very close to the prostate here, so those nerves will remain intact for this patient to maintain good erections afterwards. After that last cut, the prostate is now free. You'll see him pick it up and be able to remove it from the pelvis where it is. It's nice and smooth. And then this is the pelvis with the prostate removed. And he'll go on to sew the urethra where the catheter is here back to the bladder, which is right here. It's hard to see, but that's what he is doing. All right, and there we go. Here's the bladder, and here's the urethra coming in here. And this will be performed over a catheter. So that's why men have a catheter in their bladder for about a week after surgery, is to allow this area to heal after we bring it back together. All right, I don't know how I'm doing with time, so I'm gonna just kind of pause that right there, and stop sharing my screen. How am I on time?
Well, we thank you so much for the presentation. It was very informative, and so we do appreciate the thoroughness with which you went through everything, including our visualization at the end. So there are a couple questions in the chat. I know we were supposed to end at 7:30, but I would like to have the opportunity to at least ask these two folks questions. So the first question is, In addition to transrectal prostate biopsies, does your organization performs transperineal prostate biopsies?
That's a good question. We do. There are several of my partners that perform it. By far, the majority of us perform it with using the transrectal, but we do perform transperitoneal prostate biopsies. It's not as routine as a transrectal biopsies. There is some data that may suggest that it slightly lowers your risk of infection afterwards. We don't see a high risk of infection after prostate biopsies transrectally, though.
Okay. All right. So hopefully that answers that question. The next question I have is, for those men who were diagnosed and treated prior to 2011, and they said when the recommendations changed for less invasive, more aggressive forms of prostate treatment, are there now any new studies or treatments that may reverse the effects of a prostatectomy and permitting a more normalized functionality post-prostate removal?
There are no newer treatments for the morbidity and side effects that can come from prostate cancer treated prior prostate cancer treatment. They're about the same, and that is before PSA was a recommended screening test, and that is after PSA became a recommended screening test. So the treatment for the erectile dysfunction or the urinary incontinence that can sometimes be the result of the prostate removal has remained about the same. There is a lot of treatment for it, but it really hasn't changed in the last 10 years at least.
Alrighty. So we actually have another question, and that actually links into a question that I have as well. One of the things that was surprising to me when my father was diagnosed with prostate cancer was I had assumed that the urologist was covering all of the care. And then we had a series of new physicians we had to see, including the radiation oncologist, which I wasn't aware that we were going to have to see. So this person's question is, for radiotherapy, does your office perform proton radiotherapy?
We do not perform, and that's one that I left off, so it's a good question. Proton therapy. Proton therapy is very similar to radiation therapy. We do not perform proton therapy. There are proton centers throughout the country, and I think the closest one here is in Hampton. It's a proton center. We don't perform it, we don't offer it. We do offer radiation therapy. We have a group of radiation oncologists that work with us at Virginia Urology. So for those men that are interested in radiation treatment for their prostate cancer, we're quickly able to get them over to meet with our radiation oncologist. We have had some men that are interested in the proton therapy, and they've been able to get down to Hampton for their consultation.
Is there an advantage to doing the proton therapy, or why would one person seek proton therapy versus the radiation therapy?
It's patient preference. The proton therapist may state that there is some advantage here or there versus radiation. I don't see a huge advantage from proton therapy over radiation therapy. And this is the other thing. Radiation therapy surgery, it's been around for many, many years. Anything that is new in medicine, has to have been around for just, 20, 30 or more years. Things that have been around for 10 years is considered relatively new. And, many times the HIFU and the high frequency ultrasound and the proton therapy is just not as, doesn't have the studies to support it, or the studies from years ago to support it.
Right. Okay. A few additional questions. Are there any major risk factors for people developing prostate cancer? Like, for example, with lung cancer, smoking could be a risk factor. Is there anything with prostate cancer, or is this just something that comes with age?
Many times it's something that comes with age. Family history is going to be one's biggest risk factor. We do, and I saw more of this when I was a physician at the Veterans Hospital. Men that were exposed to Agent Orange have an increased risk for prostate cancer. And so those men that served in the Vietnam War, if they were exposed to Agent Orange, they absolutely should undergo prostate cancer screening. Before the recommendation of 55 years old, they should probably start in their 40s.
And what's about, I know you just spoke about the gentleman with the, exposed to the Agent Orange, but in general, what's about the median age for someone with prostate cancer? Like, what's the most common age you see?
I'd probably say 60, 65.
Okay. All right. Now, after someone is treated, kind of moving toward, through the treatment process, after someone's treated for prostate cancer, what kind of screenings do they have to do? I want to say for the rest of their life. So if someone's diagnosed with prostate cancer at 65, what's the process from 65 until they pass away?
Right. No, that's a really good question. Generally, after someone has had surgery, we will still monitor their PSA. The PSA is going to provide not only just early detection of prostate cancer, but early detection of any recurrence after treatment for prostate cancer. So that goes for treatment, if their primary treatment is surgery, if their primary treatment is radiation, proton therapy, brachytherapy, which is another form of radiation. We follow the PSA. The PSA should be very, very low, or what we call undetectable after definitive treatment of their prostate cancer. If it is detectable, or if it starts to rise at a certain rate after their treatment, then we have to look at if there is any recurrence of their prostate cancer. Many times that comes with imaging, PET scans, CT scans, but it just depends on the rate of rise and the treatment that they've had.
Okay. All right, so I have one final question for you. What is the best piece of advice that you would want to offer someone who's been diagnosed with prostate cancer?
The majority of prostate cancer is going to be slow-growing prostate cancer. I think it's important to weigh all of your options, even considering if your level of comfort will allow to safely observe it, because it's so important I have a lot of men that focus on treatment of the disease. And then when they get to the other side of treatment of the disease, the sequelae of the treatment really impacts their quality of life. And they didn't give enough time and consideration to the impact that can have. So if your prostate cancer is of the variety that can be observed, consider that. If it's not, just know that we have a lot of treatment options that are available for you.
Okay. Well, thank you so much, Dr. Orton. We really appreciate you coming and speaking up with us this evening. And I think our president will have some closing remarks for us.
Thank you.
Good evening. Again, I would like to thank Dr. Charity Brown for serving as the moderator for this evening's webinar. Thank you, Dr. Orton, for serving as our guest speaker. Thank you for taking time out of your busy schedule to share information with us on prostate cancer, screening, early detection, prevention, and treatment and care. We look forward to having you return at a later time to provide additional information on prostate cancer. To our program participants, thank you for attending this Men's Health webinar this evening. I am certain you have gained additional information from Dr. Orton's presentation on prostate cancer. Thank you to our technology team for providing technology services for the webinar. Again, thank you to everyone for attending this evening, and I hope you have a great evening. Thank you.